Well, good day all. Well, once again, we have another Scleroderma presentation. And I know, like many of you, are tired of Zoom, but it's an opportunity for us to get some of the leading experts and bring them to you. And today we have Dr. Laura Hummers. And, and I want to say thank you very much for you presenting today and giving us the opportunity to share your expertise with us, because it is very important that we bring to you to the patients the ideas and things necessary for them to work with their diseases. So Laura Hummers, thank you very much. And what I'll do is that for the proper introduction, I will let Michael Bessert give you the proper introduction with your credentials. And thank you very, very much again.
Hi there, I'm Michael Bessert, patient advocate, and I'd like to welcome you to today's webinar. And actually, this is my 20th webinar that I facilitated. So I want to welcome everybody to the Scleroderma Foundation Michigan Chapter's web-based educational series. This webinar is being offered as part of our strategic planning efforts to move towards web-based learning experiences for the next 4 years in an effort to reach more patients, caregivers, and family members who are seeking to obtain accurate information about scleroderma. These webinars reach scleroderma patients and their family members from all over the world, emphasizing the importance of quality educational programming for the scleroderma community. This educational program is made possible in part by grants from the Actelon Pharmaceuticals US Incorporated and Boehringer Ingelheim and the Trico Foundation. We thank them all for their continued support. Today we have Dr. Laura Hummers presenting to us, and Dr. Laura Hummers is an associate professor of medicine in the Division of Rheumatology. She graduated from the University of Rochester School of Medicine and trained in internal medicine at Thomas Jefferson University. She then pursued her rheumatology fellowship at Johns Hopkins University and has since been on the faculty working at the Johns Hopkins Scleroderma Center since 2003, where she has been co-director of the center along with Frederick Wigley. She received her degree through the graduate training program in clinical investigation from the Bloomberg School of Public Health in 2010. Dr. Hummers also serves as clinical director for the Division of Rheumatology. Dr. Hummers actively participates in a number of clinical trials and clinical investigations at the Scleroderma Center and has particular interest in predictors of outcomes in sclerodermas. Predicators, there it goes. She actively manages a large patient practice focused exclusively on scleroderma and related conditions at Johns Hopkins and actively helps to manage the Johns Hopkins Scleroderma Center longitudinal database. Presently, Dr. Hummers has established a prospective cohort of 300 patients with scleroderma being followed to identify incident vascular outcomes in the hopes of identifying new biomarkers for disease development and progression. She actively mentors several other faculty members and fellows in the Division in Investigation in Systemic Sclerosis. She also has specific expertise in other scleroderma-like conditions. Dr. Hummers.
Well, thank you so much for that really kind introduction and the invitation to speak in this webinar series. You guys are definitely a step ahead doing these webinars, given the current, pandemic crisis. So this is very much appreciated. And again, I'm very happy to be here. So my talk today is going to focus on treatment and specifically with regard to skin and lung disease. So these are two complications of scleroderma where we actually have, new trial data and two of the leading areas where we need to use immune suppressing and other medications to try to manage. But the trick with this is to try to figure out, who we should treat more than which drugs we should treat with. So we're going to walk through some of that together. So my goals for today are to review the risk for progressive skin and lung disease. And that's going to help us frame, who we think should get therapy for these complications, discuss, what the goals of treatment are, review the treatment options and discuss recent trial data and go through an algorithm of how I tend to think about management with these complications. Next slide. So we're going to start off talking about the skin, and to talk about the skin, we need to kind of think about how we classify the skin disease because skin disease is the same within scleroderma. Next slide. So we tend to break down scleroderma into two unique subsets, diffuse and limited. And that distinction of diffuse and limited refers to how much involvement there is in the skin. So patients who have what we call limited cutaneous or limited skin involvement have skin changes that are below the elbows and knees, don't involve the chest or the abdomen or any of the skin above the elbows or the knees. Whereas patients who have diffuse disease tend to have more widespread skin involvement, again, that it would include the trunk or the upper arms or upper legs. And it is this group of patients where we typically focus therapy, because patients who have this form of the disease, their skin in the early phases is going to continue to progress. And this can lead to complications, including pain and loss of function of the joints because the skin is tight. So there are pretty much two distinct presentations of scleroderma based on which kind of skin disease you have. Next slide. So patients who have the limited form of scleroderma, and again, that limited distinction refers to how much skin involvement there is, tend to have a somewhat indolent course early on. Patients typically will have Raynaud's for years prior to the other symptoms. Their skin thickening, even though we say is restricted to below the elbows or knees, very often only involves the fingers. And then patients gradually accumulate other features of scleroderma, and then somebody puts it all together and says, this is scleroderma. The skin disease is somewhat indolent, and patients sometimes don't even recognize that the skin in their fingers is tight or puffy until we point it out to them. This group includes what we used to call the crest syndrome, even though we're trying not to use that terminology anymore, just because people confuse it a little bit. And there are some antibodies that associate with this group. But the important thing to know is that patients who are in this group, for the most part, don't require therapy directed at their skin. And about 2/3 of the patients who have scleroderma have this limited version of the skin disease. So that's good news in that most patients who have scleroderma are not going to require, an immune suppressing therapy specifically directed at their skin disease. And in fact, when we have to use those kinds of medicines for other complications of scleroderma, it actually doesn't tend to make a difference in the skin anyway. Now, this is in sharp contrast, next slide, to the onset of patients who have diffuse scleroderma. Patients who have diffuse scleroderma have a pretty abrupt presentation. They can almost identify to the day that their symptoms started, because they start with this inflammation, usually in their hands and feet, where the hands and feet suddenly become very swollen. The Raynaud's phenomenon tends to be pretty coincident with those symptoms. And patients don't feel well who have this. So patients who have diffuse scleroderma come to medical attention much more quickly. And they're at risk for not only their skin progressing, but we think increased risk for some of the other specific complications of scleroderma. And this presentation associates with a couple of different antibodies as well, called SCL70 and RNA polymerase 3 most commonly. But this is the group of patients who we know their skin is likely to continue to get worse until we intervene. And although most patients with scleroderma eventually have improvement in their skin, this initial worsening of the skin, we think probably can be modified and should be modified, because it associates with other complications like contractures of the joints and pain and itch that we would like to treat.
I was originally diagnosed with limited in 2013.
Yeah.
Due to the rheumatologist looking at my other tests and then close examination of my fingernails. But it wasn't until I had the blood work and then went to the U of M where I was re-diagnosed with diffuse, because I had the ANA RNA markers. So I was, like I said, crest, limited, and then I went to diffuse. So but just wanted to throw that in there. So it wasn't determined till the blood work actually came back with the markers. So
Yeah, and the markers don't always
correct.
100% associate with the type of skin disease somebody has, but in many cases they do. And the RNA polymerase 3 antibody, for example, in this graphic, most commonly associates with diffuse kind of skin disease, and not only diffuse, but the most aggressive, rapidly changing type of skin disease. And this group is also at risk for scleroderma kidney disease as well. The centromere antibody, which associates with, again, what we used to call the CREST syndrome, those patients almost 100% uniformly only have skin tightness in their fingers, or even not skin tightness at all. So we do think that these antibodies do track commonly with the type of skin disease patients will have. Some of these other groups are a little bit more variable. So even though we teach very commonly to our trainees that the SCL70 antibody associates with diffuse skin disease, the skin disease in this group is a little bit more variable. And actually, I'll show you some data that will look at that from our cohort of patients at Johns Hopkins. All right, next slide. So what do? So we try to find this group of patients who we think are at risk for progression. And, patients who have early signs of diffuse skin disease. Sometimes if you see somebody very early into their symptoms, it's not so clear which direction they're going to go, but there are some things that will help us. So if they have a lot of inflammation in their skin, puffiness in their whole hands and their feet, a change in their skin that occurs over a short period of time, if they make the RNA polymerase 3 antibodies that we talked about, or if patients feel kind of just generally unwell when these symptoms start, we see those all as risk factors that their skin disease is likely to progress. And then you really have two options at that point. You initiate therapy right away because you just know that their skin is going to continue to change, or you can watch them very closely if somebody's not really willing initially to undergo treatment with an immune suppressing medicine. So you either intervene in that group who you know is going to progress, or you watch them very closely.
Let me just ask you this, doctor, is that when you say watch closely, what do you think the interval that you would be asking for that patient to return? Every 2 months, every 3 months, every 6 months? What is it? What is that interval?
So if I think that somebody is at high risk for having continued worsening of their skin, that tends to occur, over the first several months. So I don't think I would go more than 1 or 2 months without trying to look at their skin again. We know probably that the sooner we intervene in a group that is progressing, the better we are in terms of our outcomes. So we don't want to wait too long.
Yep. The great information, because I know many patients, how can you say, when you hear the word scleroderma, or you hear that, they become afraid. And so from that standpoint, the easiest way to deal with the situation is to ignore it, right? Yeah, no. So
yeah, no, this is definitely a case where you don't want to ignore these.
I understand. That's why I want to make sure people understand is that if this does come up, you have to address it very quickly and very closely, even though you may be reluctant.
Yep. And this is a situation where educating the patients is really important because, they may not all be being seen in expert centers where somebody really knows kind of who this at-risk group is. And it is a little tricky. The course is very variable from patient to patient. So, I think if patients are being seen outside of expert centers, giving them this knowledge, is really helpful so they can be attuned to, the changes. All right, next slide. So we assess the skin with something called the modified Rodnan skin score. And many of you have had this score done, I'm sure, where your physician tries to assess the thickness of the skin in various body parts. And this gives us a measure, an objective measure to say, okay, is the skin getting better or worse? While we use this test a lot when we observe drugs in clinical trials, it has some limitations. And I can tell you that one of the limitations is that patients can tell us if they're getting better before we really tend to see changes or significant changes in their skin score. So it does have some limitations, but this does give us a number in terms of assessing the amount and degree of skin tightness that somebody has. And this is the outcome measure for our clinical trials most often. So this is data that comes from the Scleroderma Center at Johns Hopkins. So each one of these sets of dots represents a patient's skin score over time. And as you can see, these plots go out for 15 years. And this just gives you a sense of the degree of variability of the skin tightness in different groups of patients with scleroderma. So this is clustered into groups based on the behavior of their skin disease over time. The higher the level is on this graph, the higher the skin score is, and there's more skin involvement. So the people in that upper left-hand corner there started out with a very high skin score, and their skin continued to stay high as long as we followed them. But then if you look in the opposite corner, this is where most of our limited patients are. They have very mild skin disease, and again, it just doesn't change over time. So we don't give interventions for people who have this kind of skin disease because, we don't need to. It's not going to change. So if we look at the next slide, this is the same kind of clustering analysis, same layout. So higher the level, the higher the skin score is. And this just shows you the amount of blue that's here is how many patients have the RNA polymerase antibody. And as you can see, those patients who have RNA polymerase antibody fall into groups that start out with higher skin scores. Some of them remain with a higher skin score. So that's a group of patients who have been refractory to treatment or maybe untreated. But a lot of patients start out like in the upper right and lower left boxes with high skin scores, but significantly improve over time. And that's really our expectation that, again, if we start effective therapy, that we do think that we can improve the skin over time. And the natural history of the disease is that there will be some improvement in most patients in the skin over time. And if we contrast this to the next group, which is the SCL70 positive group, you can see that that blue is distributed a little bit more diffusely, and it tends not to be in the group that has very mild skin disease on the upper left, and not to be in the group that has that high skin score that doesn't get better. They tend to live more in the middle. So they have just a lot more variability in what their skin is going to do over time. So this is a group of patients who could be observed a little bit more, whereas the RNA polymerase 3 antibody group, we know much more frequently that group is going to have progression in their skin. All right, next slide. So just some concepts of treating the skin disease. The skin has the ability to repair itself and really break down this excess collagen over time. So whatever is turning the process off with scleroderma, whatever turns it off, either drugs or the natural history, is once that happens, your body will start to break down that extra collagen over time. And that's why the skin will soften in most patients over time. So it is expected that most patients will improve even without us giving therapy. The reason we give therapy is that process is slow and patients could accumulate damage like contractures in their fingers that happen if we just let this process kind of go on its own. And the goal of immune suppressing medicines, and this is the class of drugs we use most often right now, is to stop this progression and allow the body to start to break down this collagen on its own. At the moment, we don't really have an effective anti-fibrotic agent. This means something directed at the scar tissue, the collagen itself. The medicines we do have are kind of stopping this process that is driving the production of new collagen. And this is just a graphic that shows you in a group of patients kind of with diffuse skin disease, what's expected over time. And as you can see out to year 5, there's a gradual improvement in the skin, again, even if we don't intervene with medications. But our goal with using the medicines is to shorten that timeline and to make the improvements more significant than we would see anyway with natural history. Next slide. And then one other concept I want to talk about with treating the skin is activity versus damage. So when we see somebody early in scleroderma and they have those puffy hands, like in this picture kind of on the top right here, where there's a lot of inflammation, that's what we consider to be active. And how do we tell that it's active? One, because it feels uncomfortable. Patients experience this as burning or itching or pain. There's new areas of body involvement. So the skin was thick here, and now it's thick here, and now it's thick here. And previously uninvolved areas become involved, or there's worsening in areas that were previously involved. And sometimes the tendon friction rubs, we call them, which is the tendons trying to move through this inflammation and thickening, are also a sign that there is activity. So we're pretty much would treat people who have these kind of active signs and symptoms. The question is, can there be response in people where the skin is already kind of established and thick and not really changing? And I think we have less information to say that our medicines, at least the medicines that we're using now, where we're trying to suppress the immune system, is going to help that group of patients as much as the former group. That's why most of these studies are directed at people who have early scleroderma, because we think that's where our interventions can make the most difference. And again, you can see this graphically on this little chart here. What's expected in the blue bars for diffuse scleroderma is that initially there'll be this rise and then subsequent fall. And then the yellow bars represent, again, limited scleroderma, where their skin really isn't going to change much over time.
And wasn't this a lot of the problems on early medication, is that when we didn't know as much back in the 80s, 90s, is that a lot of the drugs that were being developed, we were seeing improvement after 3 or 4 years, not really realizing that a lot of the improvement was just the nature of the disease also. So that's,
Yep.
and that's one.
And that is why, our experience with using a medication in my clinic is, if I give somebody drug X and yes, eventually they get better, I say, great, look what I did. I gave you this drug and it made you better. It is not until we do these randomized controlled trials where some people are getting the intervention you're interested in and some are not, to account for that natural history, because the expectation is that everybody will have some improvement. What you want to see is, are you seeing a difference between the people who are getting your drug and those who are not getting your drug?
Yeah, much different. And like I said, the one thing is I've noticed a lot difference is that when my wife was diagnosed, late wife, 20 years ago, is that very few drugs were out there because of that, because of the the false results. The basically, like you said, give the drug, you got better. Don't give the drug, you got better. So
Right.
so from that standpoint, it's good to see that we do have drugs that do make a difference nowadays. So, and the new improvements are greatly, like I said, I look forward to that, as more patients who have been diagnosed. There are treatments that weren't there, 20 years ago, 25 years ago.
Yeah, and I think we've learned a lot in how to do these trials and which patients we should try to put into these trials so we can really see kind of, are these medicines helping or not? I think that has evolved a lot, as much as the drugs, right, over the past several years. And I think the infrastructure for doing these trials has been put in place where it really is feasible to do trials with enough patients where we're going to be able to see a difference. All right, next slide. So this is just a very long list of medicines, of things that people are, using now, things that have been in trials or are in trials or will be in trials. And we're obviously not going to go through all of these because this would take way too long. But we're going to highlight some of the more commonly used ones and some of the ones who have been in recent trials. So we're going to start with methotrexate. Methotrexate is a drug that's been around for a while. Next slide. One more, perfect. So this study goes back to 2001, and patients were treated with fairly low dose, what we would consider these days to be fairly low dose methotrexate, 10 milligrams. This is a pill that patients take once a week. And it was titrated up to what we would consider to be kind of moderate dose methotrexate. Can you advance, please? And so this is the data from this trial, which again is, almost 20 years old now and was relatively small in size. The top line is the skin score in the patients who took the placebo. So they did not get an active treatment. And as you can see, their skin didn't really change over the 12 months of the study. And the light blue line is the methotrexate group. which did have some improvement over that same period of time. People have subsequently gone back and looked at this data again and come to the same conclusion that there did seem to be some improvement, although not that substantial, with use of methotrexate. So people were not satisfied with this as the kind of treatment for scleroderma skin disease. Next slide. The next drug we're going to talk about is a mouthful, mycophenolate mofetil, which goes by the branded name Cellcept. Next slide. So this has not been through a formal trial to see if it improves skin. Although if you survey rheumatologists, this is probably the most frequently used drug to treat the skin in scleroderma. The best data about the skin comes from the trial called the Scleroderma Lung Trial 2, which was a trial looking at lung disease in scleroderma and compared this drug Cellcept to the older drug cyclophosphamide or Cytoxan. And this graph on the left just shows you the blue is the Cellcept and the red is the Cytoxan, that in this trial, patients got either one drug or the other drug. Both groups of patients had an improvement in their skin score over time. With the caveat from this study is that patients were not selected because they had skin disease necessarily. They were selected because they had lung disease. But a significant number of patients in the trial also had diffuse skin disease. So this suggests to us that both of these therapies probably are helpful to treat the skin. And because Cellcept has less side effects than Cytoxan does, many people favor using Cellcept for skin. The next slide is a little bit of data from our center where we actually went back and looked at our experience with Cellcept in a group of patients where we were treating their skin. And as you can see in the left-hand side of this graph, this is the skin score over time. And as you can see at 3 months, 6 months, 9 months, 12 months, there was a decline in skin score. Again, these were patients selected to review who were treated specifically for their skin. The interesting phenomenon that we noticed is that, in this early experience with Cellcept, we tended to take patients off Cellcept. And we noted this phenomenon that patients would flare once we stopped this medication. And you can see in that next bar there, all of a sudden the skin is going up again. Now that is very different than what we would expect in the natural history of scleroderma, where it just kind of gets some better over time. Flare-ups are actually pretty uncommon. So the fact that this occurred, and it occurred when we stopped this medicine, to us was pretty compelling that this drug probably really is doing something for the skin.
That's what I was on, is the Cellcept. And immediately, like I said, I was diagnosed in 2013. I see Dr. Dinesh Khanna at the U of M. And I had the choice of intravenous, like IVG, and I chose the Cellcept. I started out at 2,000 milligrams, and I was on that through November of 2018. And tremendous effect on my skin. I couldn't open my mouth to eat a sandwich. My back was literally splitting open, the sausage fingers, no wrinkles, everything. It took probably 6 to 8 months before I started seeing that. Now I'm down to 500 milligrams a day. The only reason being is I started getting in my temples, like skin tabs, they call them barnacles, that were starting, and the life cycle was like weeks. So it was a side effect of that, besides the gastro, but that was easy to take care of. But I think Cellcept saved my life. But it's nice to see this, because Dr. Khanna was, like you said, I'm smart enough with my disease that I will know if it starts coming back, because I'll know what to look for. But so,
and it does flare, which again, isn't that common usually, unless we do stop a medicine that has been working. It does tend to behave kind of like the beginning of the disease again. So the symptoms that people had at the beginning tend to kind of come back again.
Right. So I just wanted to put that out there, because like I said, so far I've only been 3 months down to the 500. So I'm hoping that I won't have any more issues. So well, I'm going to, as long as I got the thing, can you go into remission? Is that possible to use the term remission, or is it a remissive state, or neither one? I mean, that's kind
I think the term remission is a little tricky,
Yeah,
because it comes
right.
from the cancer,
Right.
world. And in that, there's no detectable cancer when somebody's kind of in a remission, right?
Right.
And even though the skin will get better, there are other aspects of the disease that we think of that could still kind of crop up
Right.
over time. So I think and there are some things that will just always be problems that we just have to keep managing all the time. So like the
Correct.
Raynaud's and reflux, like those things don't usually go away. They're
No,
kind of
they
just
don't.
always there.
Yeah.
But I
they're
can
always
think of
there.
the skin as somewhat going into a remission.
Mhm. Well, that's what I like to say, more of a remissive state, because
Yes.
it's kind of like suspended animation, I try to say, because you know, you can unfreeze at any time. So I just wanted that, because I do a lot of patient peer mentoring and people throw out remission, and it's very misleading because it is associated with cancer. So I just thank you for your
Yeah,
input
and we
on
don't
that.
want people to think at all that they can just, stop going to their doctor and stop getting their
Correct.
done and their echoes,
Yep.
because there are these other aspects of the disease that could still crop up even if the skin is quiet.
Right. Because I'm on a lot of scleroderma support groups, and these so-called specialists throw that out there, that's exactly what you said. I've gone into remission. I've just stopped, and I'm going, no, 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 no. I just cautiously tell people everybody's different, and do not stop unless you follow your doctor's orders. So I just wanted to,
Yeah.
but thank you
Yep.
very much.
I
Thank you.
Yeah,
guess
and we do tend to keep people on kind of load. If we used CellCept to begin with, we tend to keep people very long term, like if not forever, on at least a low dose of CellCept to try to kind of maintain that.
And that's what I term mine is I'm on,
Retain that quiet state.
right. I call it, I'm on like a maintenance dosage. That's what I
Yes,
refer to
exactly
it.
right.
Okay, very good. Thank you.
And I
Mhm.
guess that to address your term, Mike, how can you put it, instead of remission, you might want to use not progression. So it's no longer progressing.
Right.
It's in a stable state.
Yeah, stable is probably, we can use these drugs and keep the skin stable, right? Once it's improved.
Very
Thanks.
good.
Probably
Thank
a
you.
better
Thank you
terminology.
both. Yep.
Yeah.
Thank you.
All right. So one of the most aggressive things that we can do from an immune suppressing standpoint, and now has several trials to potentially support doing this, is what's called an autologous stem cell transplant. And this little graphic kind of walks through what this means. What does it mean? So we take somebody's stem cells out of their bone marrow, and we then subsequently give them pretty intensive immune suppressing therapy with high dose chemotherapy and or radiation to basically wipe out all of their white blood cells. And then in the end, we give them their stem cells back. So the ones that we took out to begin with, we give them back so they can recover their bone marrow. So this is a mechanism to give somebody a very potent suppression of the immune system, basically kind of wipe out and reset your immune system in the hopes that will quiet down the disease. Nobody thinks this kind of therapy is going to make the disease go away, but the goal is to do something very aggressive to try to shut it down as fast as we can. And so we have two trials now, go ahead, that compared this kind of treatment to IV Cytoxan. So again, one of these medicines that's a kind of a more traditional immune suppressing medicine. And this has basically been targeted at patients who have early diffuse scleroderma. The big downside to this more aggressive therapy is that these medications in this treatment are associated with problems in and of themselves. And there is still somewhere between a 3 to 10% treatment-related mortality, meaning patients dying because of the procedure itself. And most of the time, this is because of infection, because of this intense chemotherapy. Next slide. So this is the results from what's called the ASTIS trial. This was a trial that was performed in Europe that was looking at this kind of procedure compared to Cytoxan. And if you advance one more time, as you can see in the highlighted group here, the patients who got the autologous stem cell transplant, so-called HSCT here, had a 20-point improvement in their skin score at 2 years. So that's a pretty dramatic improvement in skin score, which we don't see mostly with some of our other treatments. And in fact, the control group had less than half of that degree of improvement. They had an 8.8 point change in their skin score. So this is, and let's go on to the next slide, which shows the results from the trial that was done in the United States called the Scott trial. This was again taking this autologous stem cell transplant and comparing it to IV Cytoxan. And this looked at several years of data suggesting that patients had improved survival if they went through a stem cell transplant, and what we call event-free survival, meaning not only did they survive, but they had no significant progression in any of their major organ systems. So this again suggested that this kind of approach is helpful. But again, this has to be a highly selected group of patients because the treatment itself, is potentially very toxic. And not everybody is willing to go through that degree of risk and treatment side effects, particularly when there may be other drugs that might be helpful. But for patients, again, who are highly selected, who want to do something kind of more dramatic or have high risk features or are failing standard therapy, this is something to consider. The problem is you just can't have had a lot of damage already occur, say in your lungs, because we do worry about the risk of the treatment itself if there's already a lot of damage in major organ systems.
So is this treatment only given at certain, like I said, universities or hospitals? So that, for a patient to experience this, basically this is not going to be in your normal clinics or, type of a thing, but basically a patient's going to have to, reach out to the specialized thing to get this treatment if they decide to go down this path.
That is absolutely correct, that this is only done both in places where there is expertise in the treatment regimen itself, right? So this is performed by oncologists who actually administer this treatment because the science of this is very specialized in terms of how you process the stem cells and give them back and the chemotherapy that you give, and places who have expertise specifically using this treatment for scleroderma, because there are, scleroderma related factors that need to be considered when you're thinking about this medicine. So most of the time this is administered in academic centers, university hospitals, where there is both scleroderma expertise and stem cell transplant expertise. So that's not every center, but it is many of the major centers. And, these trials were conducted across multiple centers. So the centers that participated in this trial continue to do these autologous stem cell transplants.
Thank you, doctor.
Yep. All right, next slide. So let's talk about some of the new kids on the block here. So this drug tocilizumab, or otherwise known as Actemra, is a medicine that's approved to treat rheumatoid arthritis. It is what's called an anti-cytokine drug. So it is a drug that is suppressing a protein that mediates inflammation. And that's how it works for rheumatoid arthritis. And there has been suggestion that this is a good pathway to target in scleroderma. So this has been through 2 trials now. And the lead investigator for this has been Dr. Khanna at the University of Michigan. And what's called a phase 2 trial, an earlier phase trial with a smaller number of patients, and a phase 3 trial that had 210 patients in it. These patients had early diffuse scleroderma. And if we go to the next slide. So this is the data from the phase 2 study, the smaller, earlier study. And the 2 halves of this graphic are the placebo arm of the study on the left, and then what's called open label extension, where everybody got the treatment on the right. And the blue triangles there are the placebo group in the first part of the trial. And that patient group then went on to get the active treatment in the second half of the study. And the green dots are the patients who got the tocilizumab in the first part of the study, and then they stayed on tocilizumab in the rest of the study. And there is a little bit of separation here. If you just look at the left half where there's a placebo group and a tocilizumab group, where it looks like the skin is a little bit more improved in those patients who got tocilizumab, but this was not considered to be statistically significant. Sorry. But there was eventual improvement, even in the placebo arm once they started getting the tocilizumab. But again, it didn't quite separate enough to say, oh, there was clearly a difference between the two groups. And then if you look at the phase 3 trial, this is the results. So this is the placebo arm in blue triangles. And again, this is what happened to their skin score over 48 weeks. So this is almost 2 years. So they had some mild improvement in skin, which is again, kind of what we expect in a placebo group. But there was some more improvement, at least numerically, in the tocilizumab group. But as you can see, if you look at those kind of bars around each of those spots, there is some overlap there. So this was considered to be not statistically different between these two arms. Some people think that there are still subsets of patients who might respond to this medicine, the people who have more inflammation and more joint involvement. But at least right now, at least this trial from a skin standpoint was considered to be negative. This is a medicine, again, I think in some situations though, where we do consider using it. And the next slide.
Before you go on, just being an engineer and being analytical, I mean, was there any breakdown or graphs that represented the differences between males and females? And did we see any differences there?
Not that I recall seeing, but I'd have to go back and look specifically.
Okay, that was all, because I know we have obviously scleroderma affects women 80% to 20%, and then now we're seeing a larger degree of juvenile. So I mean, there's a lot of different things down the road and trials that hopefully that we capture and get the right additional people to participate to maybe help in those discussions.
Yeah, unfortunately, because males with scleroderma, do tend to represent kind of a small subset of the patients. In a trial like this, it's hard to get enough of those patients to know for sure if they're behaving differently. You would need a kind of a bigger study with more men involved, probably, to know that for sure. And any of these studies, once you start breaking it up into little groups, your power to really see a difference from a statistical standpoint gets smaller as you break up these groups into smaller and smaller groups.
Right, and I understand that needing placebo and the giving of the proper drug, but
right.
Hopefully down the road, and I don't mean hopefully, but is that from the standpoint that means we need more patients. I want to have less patients to be able to do that. So from that
Yes.
But I guess that's one of the questions that we hear about when we talk about it, and Michael's a great representation. Many people talk about, well, you talk about the women, but you don't talk about the men, or you don't talk about the juveniles. So I got to bring it up. So.
Yep. And men on average do tend to have a little bit more, I would say, aggressive or kind of severe version of scleroderma than women do on average. Still a lot of variability from patient to patient, but on average. All right, and the most recent trial data that we had was with drugs that affect the endocannabinoid system. So this may sound familiar to people because cannabinoids are the whole CBD trend that is out there right now. This is what's called an orally selective CB2 agonist. This means this is like a created compound to interact with the cells in your body the same way or similarly to how CBD might, except this was developed by a pharmaceutical company. It is thought to help dampen down some of the immune responses that are happening in scleroderma. And this went through a phase 2 trial, just like we talked about with Actemra, and suggested that this might actually be helping patients who have early diffuse scleroderma. This initial trial, though, was pretty small, as you can see by these numbers. And if you look at the next slide, each of these graphics represent all the parameters that were looked at in this phase 2 trial. And in the upper left, that's what happened with the skin score. So the placebo arm dropped a little bit in the skin score, but the linabacin, which is the name of this compound, seemed to have more improvement in skin score. And in a relatively short time period, this was 16 weeks, there did seem to be this separation between the two groups. Next, I think that's just blows up that skin score a little bit more closely. And you can see again at the end of the 16 weeks, there did seem to be some separation. So this went on to a phase 3 trial. And go ahead to the next slide. And if you've been following the recent news about this, there was a press release in September with the results of these studies from a large 365 patient study. This is a huge study in the world of scleroderma for a 1-year trial that did not show any difference, unfortunately, in any of the major endpoints of this study between the group that was taking the linabacin and those who were taking the placebo. This looked at a slightly different measure of response called the CRISS score, which again takes all those components that I showed you on that last slide, which includes the skin score and the lung function test and how the patient feels and how the physician feels the patient is doing, and combines it into a score. So these numbers here reflect the probability of improvement. And as you can see, those two numbers are about as identical as they can be. Now, one of the, I think, silver linings of this study is that the placebo arm of this study all did really well. So the question is, why is that? 84% of the patients in this trial were on background therapy, meaning drugs like methotrexate and Cellcept. And it's probably telling us that some of the drugs we use a lot are actually helping patients, which unfortunately made it difficult to see if there was some additional benefit of this drug. If your placebo arm is already doing really well, there's what's called a ceiling effect. You can't see much more benefit above somebody who's already doing really well. So even though this trial was considered to be negative, I do think there were some silver linings. I do think this trial will be analyzed to look and see if there were subgroups of patients, like looking at the group that were not on background therapy to see what the response was. We just don't have that data available to us yet. So I'm not sure that this is going to be totally the end of the story for this medication. It is still in trial for other indications like dermatomyositis, which is a related disease. So we may still continue to learn more about this drug or this class of drugs. Next slide. All right, just not to forget that there are other things we can do to help the skin in scleroderma to address things like itching changes and hair loss and pain. These are all things that occur because of what's happening in the skin. In advance, please. So protecting the skin when it's vulnerable, being very aggressive with moisturizers. There are medications that are directed at nerves, which can help with both the intense itch at the beginning of the disease and some of the pain that occurs. And we absolutely cannot forget about physical and occupational therapy to continue to help the patients preserve as much function and movement in their joints as possible. All right, so we're gonna leave the skin and talk about the lung, where we also have some new trial data. The problem in lung is similar to what's happening in the skin, and that there's a component of inflammation which ultimately leads to scar tissue formation. The lung, however, does not have the same capacity that the skin does to break down and improve that scar tissue formation over time. So we think that once there's fibrosis or scar tissue in the lung, it does tend to stay. So this is again an area where we focus on preventing progression. Many patients with scleroderma have lung disease. The important thing to know is that even though we can find scar tissue in the lung, in most patients who have scleroderma, only a small subset of those patients are going to have that fibrosis continue to progress. So this is another situation where we have to either predict who's going to have that progression or treat patients who have already shown signs of progression. But there is room for observation in people who we think are lower risk. Next slide. So who is at risk? People who have diffuse skin disease are more at risk than people who have limited skin disease. The SCL70, or what's called the topoisomerase 1 antibody, we think of as being higher risk. People who are early in the disease course tend to have more decline. We think that our African-American patients might have an increased risk of progression, and patients who already look like they've had fibrosis development when we first assess them, meaning their lung function is already low, or they already have a significant amount of scar tissue on their CT scan, those patients are likely to continue to progress. And then we direct therapy at treating this group who either is progressing or we think is at high risk for progressing based on some of these features. Next slide. If you have a totally normal CT scan at baseline, 84% of those patients will continue to have a normal CT scan 5 years later. So that's reassuring if when we recognize scleroderma the first time, if they have a CT scan that is normal. And actually the patients who make centromere antibodies and RNA polymerase III antibodies, we think are less at risk for progression. And we tend to watch these groups more often and don't have to treat them as often. Next slide. So all scleroderma patients get a PFT and probably a CT scan at baseline and as early as possible. And patients who are at risk that we're not going to treat right off the bat if they already have a lot of disease, we repeat that breathing test more frequently every 4 to 6 months. And lower risk patients, we tend to repeat the breathing test every year or if they develop new symptoms. And while everybody probably should get a CT scan at the beginning, we only repeat CT scanning if there's been changes in the breathing test or new symptoms develop and we're not sure why, to look as another way to assess for progression. So this is just, again, graphics that come from our center just to show that on average, this is what is looking at the lung function change over time. Again, this is 15 years of data. That patients on average who have diffuse disease on the left-hand side tend to lose a little bit more lung function than people who have the limited skin disease. But as you can tell, in each of these, this is called a spaghetti plot for obvious reasons, each one patient represents a line. There's a lot of variability in those squiggly lines over time. So again, on average, people with diffuse scleroderma have more lung function, but there is a lot of overlap between these two. And similar in the next slide, is looking at the SCL70 positive group and the SCL70 negative group. So on average, the SCL70 negative group on the left has pretty stable lung function. But again, look at all the variability between the individual patients. And then the SCL70 positive group on the right-hand side, on average, loses a little bit of lung function over years. So helps us a little bit to say what we think somebody's risk may be, but doesn't tell us definitively if having diffuse skin disease or SCL70s means that you're absolutely going to change because there is a lot of variability. Go ahead. So the first study that looked at treatment for lung disease in scleroderma was called Scleroderma Lung Study 1, and this compared oral Cytoxan to placebo. So this was the kind of initial study looking at immune suppressing medicines to treat scleroderma lung disease. Next slide. And this study suggested on average that patients who were treated with cyclophosphamide had a little bit of improvement in lung function over the first year, whereas people who were treated on placebo, bottom right, more often had worsening of their skin disease. And there was a statistically significant difference between those who were treated with Cytoxan and those who were treated with placebo, suggesting benefit of the Cytoxan. Unfortunately, this medication comes with a fair number of side effects. So again, we were always looking for kind of a better solution than this drug. Next slide. So that's where Scleroderma Lung Study 2 came into play. So they compared this drug that we just showed in Scleroderma Lung Study 1 that had some benefit, Cytoxan, and compared it to Cellcept. And this is looking at the lung function parameter over time and shows that both groups, the solid line is the Cytoxan group, the dotted line is the Cellcept group, both groups had some improvement, this is actually out to 2 years, in their lung function over time. And that difference between the two was not significant. However, the side effect profile between these two was significant. More people had side effects with the Cytoxan than the Cellcept, which again has led to Cellcept really being kind of the first line therapy for most patients if we're needing to use something to treat their lung disease. So again, we have a new kid on the block in terms of scleroderma. So this is the data from the Census trial, which looked at a drug that is an anti-fibrotic drug. So this is a drug supposedly targeting the scar tissue component of scleroderma. This is not an immune suppressing drug. This is a success in the sense that this study enrolled 576 patients with scleroderma with lung disease. This was multinational study, 32 countries, which in and of itself is incredible that we're talking about a scleroderma trial that had 576 patients in it. This was a randomized placebo-controlled trial, meaning half the patients in the study got the treatment, which is called nintedanib, or its branded name Ofev, and half the people got placebo. And this study went on for a year. And the measure that they were looking at 1 year was the lung function parameter. Next slide. So this is the data from this trial that led to the approval of this medication for treatment of lung disease. The graph on the left shows what happened in milliliters to the volume of lungs. So when we're measuring the lung function test, that's what we're measuring. And the people in the placebo arm, which is the light blue bar, had a bigger drop in their lung function over the 1 year than patients who were treating the nintedanib, who were treated with nintedanib on the left in the dark blue bar. Both groups over time had a little bit of decline in lung function. However, nintedanib seemed to prevent the progression of lung function compared to the placebo arm. So they lost only about a half amount of lung function as the people who were treated with placebo. And again, just for comparison's sake, Scleroderma Lung Study 2, which looked at CellCept and Cetuxan, both of those groups suggested a little bit of improvement in lung function. So this is a little bit different in that it showed lack of progression, but not improvement on average. Next slide. And when they did a lot of what's called subgroup analysis, again, with 576 patients, you can actually do some of this reasonably to look to see, oh, was this treatment effect with this drug limited to a specific group of patients? Was it different if you could looked at age or race or gender, like we talked about before? And really, it seemed like the effect was about the same any way you sliced this group. So it didn't really appear to be a different result based on gender, based on age, based on what country you were in when you did this trial, if you made that SCL70 antibody or not, what kind of skin disease you had. And importantly, I think for us, whether or not you were taking background CellCept. So about half of the patients in this trial were taking CellCept in the background and half were not. Both groups seem to show some degree of improvement when this medication was added on, whether you were on CellCept or not. So this led to the first approval of a medication for a drug to treat this complication of scleroderma, and this occurred last year. Unfortunately, let me go back one, sorry. I should mention that about 75% of the patients in this trial had side effects. And the most common side effect of this medication is GI side effects, most commonly diarrhea and weight loss. Those symptoms can be managed with medications or adjustment in the dose of this dose of the nintedanib, but it is somewhat of a limiting side effect. The good news is that people had to reduce their dose in the study. It still seemed to show benefit, even if they had to use the lower dose because of side effects. And then the last thing I want to mention is we talked about the tocilizumab trial with regard to the skin disease. And again, this was a trial that was focused on patients who had early diffuse skin disease. But somewhat surprisingly, I think, when they looked at the lung function in this trial, both the phase 2 trial on the left, other way, phase 2 trial on the right and the phase 3 trial on the left showed that lung function was preserved in people who were treated with tocilizumab, whereas those who were in the placebo arm had decline in their lung function. Again, this was not the primary reason that this drug was used. This was used primarily in a group of patients who had active skin disease. But, you know, this data is pretty compelling that this drug may play a role in preserving lung function amongst a group of people who have early diffuse disease. So I think exciting news on the drug front with regard to lung disease and scleroderma. Other things to not forget about when you're treating the lung is that we really want patients to exercise to try to keep their heart and lung healthy as best as possible. For people who have a significant amount of lung disease, we do recommend that that at least starts in the context of what's called pulmonary rehab, where you go through a monitored, observed exercise regimen. And at the end, patients have a regimen that they can do on their own. Oxygen therapy in people who need it. And very, very importantly, is to make sure we're aggressively treating GERD if that's an issue. Reflux, we think, could play a role in be part of what's aggravating the lungs to begin with. And some people think that this may be playing a role in development of fibrosis and scleroderma lung disease. And we have lots of things to do to treat reflux. So we really want to be aggressive about treating reflux, especially in patients who have lung disease. Most of the time when I see cough in my patients, even patients who have lung disease, it is the reflux that is the cough. That's what's driving the cough. So we have to make sure we're aggressive in terms of treating the reflux. And then, so these are just some of the things that I think about in terms of when I'm treating a patient. Am I treating just their skin? Am I treating skin plus lung? Do they have muscle or joint issues? And we didn't get to talk about all of these medications, but the good news is that I feel like I have a group of medicines that I go to when we're thinking about treating all these different combinations of things. And I'm sorry we didn't get to talk about all these medicines or all these complications of scleroderma. But again, I think, now we have a group of medicines that we have some data on that, we think might be helping our patients. Next slide. And so just to conclude, there are subsets of patients who require therapy for their skin and lung, but not everybody does. In fact, most people don't for either. We do use all of these things to try to assess what somebody's risk might be to see if there's going to be progression. And we try to determine the activity of the disease or if somebody is progressing. We treat those who are definitely progressing or high risk for progressing. And the amazing thing is that we have new trial data now for new drugs, and it's really changed the way we're thinking about who to treat and when. Every trial we do, even if it's a negative trial, is telling us something about scleroderma, and we are learning. So everybody who's participated in all these trials has done a great service to the scleroderma community, even if the trial doesn't lead to a new drug approval. So we are always grateful to the patients who participate in these studies. And I think I will stop there, and we'll take any more residual questions.
Let me just say, I'm going to use a phrase that Dr. Mays, and I'm sure you're familiar with Dr. Mays, is that
I am.
So we had her on as a presentation, is that as Michael was alluding to, there's no cure for scleroderma, but it's how to manage it. And I think right now is that what I have seen over the 20 years or 20 plus years, like I said, my late wife had it. And when she was diagnosed back in the 90s, is that these drugs that you have at your fingertips now were not available. And, back then the doctors would give you you have 5 years to live and put your things in order. That's no longer true. And that was a false statement back then. But that was because of they didn't know what to do. That they didn't have I should say, the bullets in the gun to go after the disease. And now with a lot of investment and research by people like yourself and other doctors at the universities have now given, the doctors the additional ammunition to address the symptoms and to try to treat it, to lessen it. And this is great to see. And I hope that just from the standpoint that it gives the patients that are viewing this hope that is saying, hey, there are things that we can do. I can take, and I'll rewind this presentation and I'll copy this slide and I'll bring this to my doctor and says, hey, is this applicable to me? Can we do something like this? And they might not know, and they might refer you to another, doctor at another university. And that's the power of this type of learning and sharing with one another. So I want to say thank you very much for the presentation today, Dr. Hummers, because this this is great news for patients out there. And knowing that, you know, like you said, it's not just John Hopkins, but the last study that you show with 572 patients with 32 countries, that's exciting to me.
Yeah, I mean, it's incredible. Like, I don't think if you had asked me 10 years ago, would we be talking about a trial that had 576 patients in it? I would say no way. So I think the scleroderma community gets some credit for that, for pulling together. I think the pharmaceutical companies are more willing and able to do trials like this now. And obviously it doesn't happen at all without the patients being invested and interested and willing to help. So it's a huge effort. But, you know, as we can see, this is what we need, is to do these kinds of trials. And hopefully now we can continue to do more of them.
So I want to say thank you very much again, Doctor. And
oh, sure, it's an absolute pleasure.
And with that, I'm going to let Michael wrap this up for us today. And like I said, you know, once again, the Zoom technology has become a standard practice in our life. Sad to say, but from that standpoint, but it does have its benefit in being able to share this information with people around the world. So thank you very much. Michael?
Yes, and I agree with everything John said. What a wealth of information you have provided, because number one, being a patient advocate, I learn doing these, and I love doing these because it helps me, and then I can help others by doing this. But I want to go back to one important thing you said. It was about your routine testing and stuff. So this stuck out in my mind is don't ignore push, because that's pretty much how I got to where I was, because I pushed. Because like I said, I was diagnosed when I was 55 years old, and I had to argue all the way because I said, I'm 55. I know my body. There's something wrong, you know? So I pushed and pushed, and I got a little aggressive in it, but I got a diagnosis. But it also helped because I received early treatment. I received it before the arch. So I think a lot of factors, plus the first rheumatologist I saw was old school, that basically, like John said, told me, put my affairs in order. I then was referred to the University of Michigan Scleroderma Clinic, and luckily got Dr. Khanna, and he restored my hope, and he continues to do it today. So I would like to thank you all for viewing this webinar. Staying educated about scleroderma is so important. This is the reason the Michigan chapter strategically has created web-based educational experiences. Being educated can help scleroderma community become better health care advocates. I hope you'll join us for all our educational webinars. And for more information, check our website. This is all small letters, scleroderma.org/Michigan, or the National Scleroderma Foundation weekly e-letter that is delivered to your email every Friday. Thank you again for sharing your time with us on this webinar, and have a great day.
Thank you, Doctor, again.
Thank you, everybody.
Thank you.